Jagma sir is ready. We'll start.
Yes, sir.
Yeah.
Good evening, everyone. I welcome everyone to this today's webinar, a part of Professor AD's Virtual Clinics for Postgraduates 2.0. Today we have our guest speaker, Professor V. Singaravadivelu sir, an eminent teacher who is the Professor of Orthopedics and the Chief of Orthopedics at Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. Sir is currently the Vice President of Tamil Nadu Orthopedic Association as well, and he was a past President of Madras Orthopedic Society as well. Sir is well known for his teaching capabilities at MMC and as well as in other parts of the country. He is currently the examiner for MS Ortho as well as DNB Ortho. So we are very happy to have you in our program, sir. A very warm welcome for you, sir. And as usual, the program will consist of, sir will be discussing about the clinical examination of bone tumor cases. And at the end of the session, we'll have a polling session wherein there will be few questions and the attendees can answer their questions via the Q&A section, or you can raise your hand and we'll unmute you so that you can answer the questions directly. So I welcome you all once again, and over to you, sir. Professor VSV, sir. You can proceed with the presentation.
So, good evening, everyone. Thank you, Dr. Jaykumar, for those kind words. At the outset, I wish to pay my humble respect to Professor A. Devadas, who is the doyen of orthopedics and who we have been fortunate to listen to him, his clinical class as well as his lectures. So, I wish to pay my respects and thanks. And I wish to thank the entire IORAS team, Dr. Satish Devadas, Dr. Jaykumar, and the entire team for having given me this opportunity. So with those few words, shall I start sharing my screen?
Yes, sir.
Yes, please, sir. Yes.
Yeah. So is my screen visible?
Yes.
We are able to see.
Yeah. Thank you. So now let us go about the clinical examination of bone tumors. So nowadays the youngsters, for any question, they seem to have their answer in their pocket. So any question we ask, immediately the answer comes. And last week when I was going for rounds for a lower femoral pin traction, where is the site of entry and what are the precautions you should take? The PG was not able to. And next day when I asked him, what is that? What are the various sites for various pin traction? He just said something and something were wrong. When I was just asking him, which book did you read? Sir, I read it in a journal. So they have a mobile, they have an internet, and they think that they have all the answers in their pocket. So in this era of fantastic imaging studies, is there a need for a clinical examination, that too for a tumor? So if there is a tumor in a young girl around 15 years, presenting with a huge swelling in the lower thigh, it itself tells, and the X-ray, the classic sunburst appearance. So osteosarcoma. So should I need to examine this patient to find out all these things? And is there a need for a clinical examination class presentation? So this I saw around 1 year ago, this patient. He is another young boy, 15-year-old. And he has gone to another orthopedic surgeon. So he has examined, they have found out a lesion in the distal femur, the lateral aspect. So he thought something benign and he can get away with just opening, making a window and curating, and that ends the story. That's what he thought, and this is the procedure that was done. But unfortunately, it turned out to be an osteosarcoma. So when we are planning for a limb salvage, the entire incision had to be modified so much, so violent it had to be for dissecting the distal femur. And follow-up, there was skin necrosis here, obviously, because of this modified incision. The plastic surgeon, of course, they had recommended, but the amount of elevation and all those things has caused this much of necrosis. And this is the results. Anyway, the patient came out and the patient is doing well, but so much of complications. And this one incision itself can preclude whether it is limb salvage or it is going to be a limb sacrifice. So clinical examination, whatever the gadgets might come, it is very important. You have to make a diagnosis. You have to suspect what is the problem before we take the help of the technology. And then definitely technology is helping us, and without technology we cannot. But we need the clinical examination and mentoring for us to proceed. So with that, and this webinar is not going to be on the entire exhaustive presentation of all tumors. So this is not what I'm going to say. All tumors, what are the types and the cell of origin and benign, malignant, and what are the characteristics and what is the X-ray appearance and what you are going to do. So this is not going to be like that. So this is going to be a clinical examination. How do you approach the patient and how do you diagnose and what are the things you are going to say in the examination? So what is that as examiners we expect from the student? So if a patient is presented to you with a problem, a tumor, or for that matter anything, first is you will have to say the provisional diagnosis. So don't confuse infection and neoplasm. Sometimes it may be, but most often it is clear cut if you elicit a careful history and examination. So you have to make a provisional diagnosis and you must have your own reasons. So don't say a very benign tumor and also a very aggressive malignant tumor. So whether it's a benign, a locally aggressive tumor, or is it a malignant tumor? First, you'll have to say that. Once you have said that and you have told the diagnosis, what is a provisional, if needed, you can just give a differential diagnosis. And if you have a differential diagnosis, you should say why it is so and why it is unlikely. So then you have to tell the investigation, don't start from blood TCT CSR. So what are the basic investigation you need to establish the diagnosis? Second is the investigations for, if it is a malignant tumor, for the presence of metastasis. Very, very important. Many students, they miss it. And you must always never forget, don't jump into, I'm going to do a limb salvage surgery, I'm going to do an amputation, a radical resection, or whatever it is. Don't just say that. Always, any tumor, unless it is so obvious like this, you have to have a histopathological examination, tissue biopsy report before you proceed on to further management. Then you'll have to tell about the management. So this is the way you have to organize yourself and you have to present. So when it comes to history, what the patients can come to you, the patient can present with pain, they can come with swelling, or both together. Sometimes they can also present with deformity. So tumors like fibrous dysplasia or multiple exhaustosis, they can present with some deformities like that. So this also may be because of a tumor, a deformity. So that you should remember. Restriction of activity. So all those things you will have to say. Pain, if you are telling what is the type of pain and how severe it is and which came first, all those things. Of course, you will be knowing that. Then the onset. So when did the patient notice? Most often there will be a history of trauma that brought notice, or the pain. So patient might have been having a pain which gradually increased and then they have started noticing the swelling or anything if it is malignant, or a sudden growth spurt or some reason there may be for the increase in size of swelling, and then they may present with swelling when the patient might have diagnosed. So you have to carefully elicit what was the reason, how they recognized that there is a problem, and what is the progression. Is it within which time, from the time they observed to the time now? So how did it progress? And most of the cases, there will be a history of trauma, whether it increases the propensity of the tumor or not. So that might have brought the patient the attention to the problem also. So there may be a history of trauma. So one thing is that some students have been misled by the history of trauma and going into the traumatic history and telling something as a trauma problem. So don't fall into the trap. History of trauma, whether the patient was able to immediately stand and walk, the patient might have done that. And as the patient was continuing his activity, he must have noticed that the activity was gradually getting reduced and he might have started noticing swelling. Everything he'll attribute to trauma. So a progressive increase in size of the swelling, and which was brought about by the trauma that the patient might have noticed, and gradually the problem becoming more, which the patient was able to walk and do everything, and the problem becoming more, should give you the caution that it is not simple trauma and that is something beyond that. And constitutional symptoms. In tumor, there may be constitutional symptoms, like if there is Ewing's tumor, it can mimic osteomyelitis. So there may be history of fever, there may be constitutional symptom. Apart from the loss of weight, loss of appetite, and the characteristic features the patient may be having, even history of fever with rigor may be present in some conditions like the granulomatous tumor or fibrous histiocytoma or the Ewing's tumor. There may be constitutional symptoms also, right? When coming to the pain, so how do you differentiate between a benign swelling and a malignant swelling from the pain? As we already said, that pain will be coming later once the swelling is noticed, because pain may not be there and the patient has noticed swelling, and gradually seeing that he might have a feeling that there is a mild pain there. So there may be none or mild pain. There can be a dull ache, the characteristic. It will not be sharp as malignant. It will be a dull ache. It is low in onset and it will not be that much progressive, the pain. If there is pain, it will be relieved with rest and drugs. So it will not be disturbing the sleep. The pain will be relieved with rest and drugs completely. If there is a sudden onset of pain in a benign swelling, there may be a pathological fracture. The patient, a young boy, the simple bone cyst, it might be brought out only with a pathological fracture. Patient was all right, they might not have noticed a swelling, and suddenly complaining of pain, and you notice that there is a simple bone cyst. So pathological fracture is one cause for sudden onset of pain. In benign conditions like osteoid osteoma, you all know there is a characteristic pain. There may be neck pain, and the pain is relieved by aspirin, the prostaglandin inhibitor. You all know. So this is the characteristic of osteoid osteoma, which you must be remembering in pain in benign tumors. About malignant condition, how the pain in malignant condition it differs. Pain may be there before the swelling, and it is very severe pain, sharp pain, and the pain is very, very severe. So it is not relieved with your routine drugs and analgesic. There may be some decrease, but it is not relieved, really relieved. And the most important is it disturbs the sleep. So it is not like patient who are stressed out and the sleep disturbance is there, the patient is saying. The patient goes to sleep and the pain disturbs the sleep. So this is very, very important symptom which I feel that all the young orthopedic surgeons and postgraduates must realize. If someone comes to you, a middle-aged man or an elderly person, he says that severe pain and the pain is disturbing his sleep, you must always think and search for something if you are not able to make a diagnosis. Not completely related with drugs. So with that history and all the other history, general history, you come to the examination. You start examining the patient. So the site of the swelling, if there is a swelling, you start seeing the site of the swelling. So a condition like this, if it is, you all know that it is an osteochondroma, the exostosis. So it is arising from the tibia, but the swelling is presented in the lateral aspect, the fibular region. So you have to be very careful. It might be impossible also till we take an X-ray to find out that it is from tibia. So one of my teachers used to say, if it is from tibia or fibula, how you diagnose is that you measure the individual length of both the tibia and fibula and compare it to the opposite side. Usually, if it is from tibia, there will be some shortening in the tibia when compared to the normal side. So that is one. So you have to find out from where it is arising. Second thing is, if a swelling like this comes, always examine multiple sites. So even last week I saw one child that the mother was complaining around 8 years. The child was not complaining. Mother was complaining that there is a swelling there in the tibia. Started examining. You have to just run your finger in the back, the chest, and in the back. So the exostosis, many a times, commonly it can be presenting with deformities and patient themselves will say. But if it is not so, if it is a subtle case, so if they are coming very early, it may be very, very concealed. You have to see that. So in the examination, if you fail to observe that there are multiple exostoses and you have seen only one, then that may be a serious misgiving. So you have to find out where it is arising from, the size. You have to tell the location where exactly it is. It is above the patella or from the knee joint and how much it is going above. It is on the medial side involving the anterior and the lateral side. Whether it has, you always remember to see the posterior aspect also. Whether it has gone to the posterior, because it is a central, the bone is centrally located. So if you may be able to see it anteriorly, but you have to see all sides to find out what are all the structures it can compromise or it can affect. So the size you will have to say. The extent, which I was mentioning, you have to say the extent, anterior, posterior, medial, lateral, superior and inferior. And the skin. Skin, when it is stretched and shiny, you will always know that it is a rapidly progressing tumor that is going more in towards malignancy. And the skin with some wrinkles is normal skin. If it is there, then the skin has had time to stretch. So it is a slow growing tumor, so likely to be benign. And whether there are any engorged veins are there over that skin. So if you are telling about the skin, you have to look for any venous engorged veins which are there, are very, very important. So in our people who are little dark skinned, you have to really see in light and find out whether there are any engorged veins. They are all very, very important for you to establish a diagnosis as well as for the examination. You'll have to say that. So the engorged veins are important. And if there are ulcers that might have fungated, if it comes late, or it might have been done already and recurring. So the examination of an ulcer, so right from base, the margins, how it is everted, and it is fungating growth, bleeding on touch, and everything you'll have to mention. So the inspection, you will have to say all these things. Then come to the palpation. When you are coming for palpation, you will have to say, as any other region or any other system, you'll have to say warm, because that is the one which will get lost when you don't say that. See that first. So whether it is warm. Then tenderness, you will have to say. The swelling might be there on one aspect you might be seeing. It may be, for example, on the antral aspect of the distal femur. So you will have to see the medial aspect, posterior aspect, whether it is tender. Tenderness gives you a clue the extent of the tumor also. So how far it is extending. So this tenderness you will have to see. You have to be very gentle. The patient's, because you should not be releasing too much of pain to the patient. But anyway, you have to see that. Then the margins. So is it well defined or is it merging? So where you are able to see the normal bone, I am able to feel the femur up to the mid-third, lower third junction, beyond which I am not able to feel the femur distinctly on the medial side or on the lateral side. And then the margins are well defined or it is merging. So that you will have to say. The consistency, you have to palpate everywhere, whether it is uniformly hard in consistency, bony hard in consistency, or in some places there are some soft or soft firm in consistency, because that tells us about the aggressiveness of the tumor, whether there is any necrosis which is happening, whether the tumor is very soft and very rapidly growing. So this consistency you will have to see in multiple places. So if you are seeing swelling, fluctuation, you should remember our undergraduate days, cross fluctuation in both planes. So all those things you have to remember that. And crepitus and eggshell crackling, which is characteristically mentioned in giant cell tumor, you should not elicit that sign. When you are palpating, if the bone is yielding and you are feeling some crepitus, you can tell the examiner, I did not palpate for the eggshell crackling, but still there was crepitations when I was palpating. That you can mention. But this is a sign which you should not elicit, try to elicit. So if you are examining, as I was mentioning, a scar you have to mention. One more thing is the receding index finger you have to see. So if you see the knuckle, that cascade or the arcade is there or not. So if you, unfortunately I don't have, because the patient was not able to flex the index finger. It was an enchondroma which was operated and recurred. So in this case, there was shortening on the metacarpal bone. The index fingering is becoming short and it is getting telescoped in. So all those findings you will have to say in examination before going in for the diagnosis. These subtle findings you will have to say. And most important is whether the joint is involved or not. A tumor which is almost extending up to this, whether to say the joint involved or not. We all know that an osteosarcoma, there may be metaphyseal origin. So the joint will not be involved till very late when the tumor grows too much. So when the joint is not involved or not, how are you going to say? So for example, this is an osteosarcoma, distal femur. You can see the extent. So medially it is more, so anteriorly and laterally. Then you will have to see really close the engorged veins, what I was mentioning. You will have to see the engorged veins are here and here. So I'm able to see two veins. So you cannot expect in a fair-skinned people that really big engorged distended veins. So you have to be in good light. You will have to see for the engorgement of the veins. And then you should not forget to see the posterior aspect. So you can see in the posterior aspect also, on the medial side it is extending, but in the popliteal and the lateral side there is not much of an extent. So having said that, how are you going to say that whether it is joint is involved or not? It looks like it is extending up to the joint. Is the joint free or not? So for that it is very easy if you just flex the knee joint. If you flex the knee joint, this is where the joint line, you can see the subtle depression. So this is the joint line. So this joint line you can easily see, and you can palpate the sharp margin of the distal femur and the proximal tibia. The tumor is confining itself to the metaphyseal. So these kind of things you will have to do to tell the examiner that, sir, this is a metaphyseal. Why do you say it is arising from the metaphysis? The joint is free. Joint is not involved. You cannot say that the movement is full, because there will be mass which is there also in the popliteal region, and it will be restricting the range of movement. So with that you cannot say. So you have to flex. You have to convince the examiner that you know that this is, you have not got a clue, and this is a straightforward case, but still you are flexed and you are able to see the joint line, and you are able to palpate the joint line, the sharp margins, and the tumor is just above that. So that you have to say that this is a tumor which is arising from the metaphysis. So then you will have to say few things like whether there is any pulsation, because there are pulsatile secondaries, thyroid or renal malignancies can be very vascular, and it can be pulsatile, because in my examination a secondaries was kept which was pulsating. So you don't think that suddenly for our examination patients will come like that. So you have to be wary of that. So pulsatile, whether it is there, if it is there, you have to find out whether there is any bruit, and never forget the distal neurovascular examination and proximal lymph node. So these are two things which you have to say. So the proximal distal neurovascular, we have to say the individual vessels, and then, because very, very important, whether you are going to do a limb salvage or you are going to sacrifice based on that. And proximal lymph node also, don't think that there are few tumors which can spread to lymph nodes, like malignant fibrous histiocytoma can spread to lymph node. So lymphoma, whether it is primarily from the bone, it has gone to the lymph node, or the other way around, we do not know. But there are conditions. So if it is an infection, already something done. So infection, lymph node palpation will be important. So for all these reasons, don't forget the basics. Don't just confine, though it may be a short case, because you do not know when an extraordinary finding which the examiner finds and we are not able to find out. So those things you have to see that. And the other system you have to make a mention, the cardiovascular system, respiratory system, and the abdomen, you have to do it before you conclude, because most of the time they may ask for the diagnosis and then they may go back. But still, for completion, you have to go in an orderly way, as well as for your practice. This is not only for the examination where your acumen, it starts getting applied in your practical thing. So once you have completed your examination, then you will have to say as provisional diagnosis. It may be obvious, distal end of radius, and if you don't have anything, you can say stick on to that. But if the examiner asks, then you may have to say why it is not an irreversible bone cyst, or why it cannot be infection or anything. You have to substantiate. Then you have to tell about the investigations, then the biopsy as already told, and then management. So far we have discussed something about the clinical examination. So these are all the things which you should not miss. Regarding the imaging, I will not go in detail, but certain salient points which in the orthopedic examination you must be knowing. So the imaging, plain X-ray is very important. The role of CT scan is to find out whether there is any pathological fracture, how much the bone is involved. If there is any ossification or calcification which is happening in the tumor, you may not be able to find out if it is not found in the X-ray, normal this thing, a CT scan X-ray. If it is not there, then you may have to see a CT scan. Then an MRI. MRI is to find out the soft tissue extent and how far intramedullary extension of the tumor it can very well bring out. If there is another focus skip lesion, if it is there above, it can say. Then the role of radionuclide scanning is very, very less. Don't say routine everything radionuclide scan, because normally for a primary tumor, you don't do all these things, because if it is a secondary, if it is suspected multiple skeletal metastasis, if you are thinking, radionuclide scan helps. But for a routine orthopedic oncology, a primary tumor, it may not be very much relevant. So there are some tumors which are cold, like multiple myeloma. It can be cold also in a radionuclide scan, isotope scan. You have to be wary, and especially the PET scan also. For a recurrence, for knowing the activity of the metabolic activity of the tumor, you need to know about the PET scan, not as a routine. For your management, when the patient is presented, these two may not be that much essential for your management. Now, when the X-ray is put, you have to go in an order. So tell about the size, site of the lesion, borders of the lesion, then the zone of transition, how the normal bone from the normal bone, how the disease or the disease bone where it merges become the normal bone, what is the type of destruction the tumor is doing to the bone, the periosteal reaction, whether it is there, the matrix of the lesion, what the tumor is doing to the matrix of the bone, and the nature and extent of the soft tissue involvement, and whether any multiple involvement is there. So having said that, there are to diagnose the tumors, there can be few clues and you must be aware of all these things. So the site, what is the type of bone? Is it a flat bone or is it a tubular long bone? Is it where is it involving? Is it an intramedullary? Is it eccentrically situated or is it a cortical lesion? Where is the epicenter, which we'll discuss it later. So even though the tumor is huge, so it starts somewhere and you can find out easily in the X-ray. So it helps to determine the origin, whether is it coming from the bone going out, or is it in the cortex and it is destroying, or is it outside which is coming in, and which part of the bone is it involved, epiphysis, metaphysis or diaphysis. So these are the various tumors and where it is common, where it commonly involves. So it can rarely involve the other eye sites also. So the Ewing sarcoma can affect we commonly say that it is diaphysis, but it can be in the metaphysis. Rarely it can from the epiphysis. So that this we can go through, any standard textbook will give. And also the certain bones have predilection for certain tumors, which you should also know about it. Whether it is eosinophilic granuloma or the mandible, all those things. Humerus, the simple bones, the ribs, metastasis and chondromas. So if you come to the knee, where commonly happening, the osteosarcoma, Ewing tumor, almost all tumors can be there from the knee. In tibial shaft, the adamantinoma is one. The osteoma can commonly occurs there. So like that, you must know, you must have an idea which bone has got predilection for what tumors. You must have some idea. And it is this you can remember a little easily. In the epiphysis, chondroblastoma that can be there in a child. In adult, it can be a giant cell tumor or an aneurysmal bone cyst. So if it is in the metaphysis, a fibrous cortical defect, an non-ossifying fibroma, or it can be an osteochondroma or osteosarcoma. Fibrosarcoma, the other things, the chondromixer fibroma, aneurysmal bone cyst can go there, and an enchondroma. A simple bone cyst can be there. And in the diaphysis, the adamantinoma, the osteoid osteoma, the fibrous dysplasia, the round cell tumors like Ewing's tumor. So all those things. So each area of the bone, the epiphysis, the metaphysis, or the diaphysis, then the certain tumors are prevalent. So the same thing which has been described again, whether it is in the epiphysis or in the metaphysis or in the diaphysis, the benign tumors and the malignant tumors. Then whether the child has attained skeletal maturity or not. Certain tumors are common in children, certain are after the skeletal maturity. So chondroblastoma, commonly it affects only in the children. It is one tumor which crosses the physis, we all know. So it can be in the epiphysis, it crosses even though the growth plate is there. For most of the tumors, the growth plate is a barrier. But this chondroblastoma, it can break the barrier and it can be in the metaphysis, epiphyseal and metaphyseal. A simple bone cyst, the osteosarcoma, aneurysmal bone cyst, enchondroma, the osteoid osteoma, non-ossifying fibroma, the osteofibrous dysplasia, the fibrous cortical defect. These can be present in the children, immature skeleton. When the epiphysis is closed, the giant cell tumor, myeloma, the cortical metastasis, the adamantinoma, chondrosarcoma. So this chondrosarcoma and second group of osteosarcoma are one of the tumors which come, and also of course the multiple myeloma. So they are the malignant tumors which come late. The rest of the tumors like Ewing's or osteosarcoma, they come before the epiphyseal plate fuses. So these are the tumors based on the epiphyseal closure or not. And the epicenter I was telling, so is it a central, eccentric, cortical tumors or a parasteal or an intra-articular? So based on the epicenter, the tumors also can be, you can find out where it is, whether it is a central like a simple bone cyst or an enchondroma or fibrous dysplasia. They are more commonly central. The other giant cell tumor or the aneurysmal bone cyst, all those things, they have an eccentric or it expands. And so that is how you differentiate. And coming to about the vertebra, there can be tumors in vertebra. So malignant lesions are common in the anterior part, and benign lesions predominate in the posterior part. So the lymphoma, myeloma, osteosarcoma, Ewing's chondrosarcoma, metastasis, these things happen in the anterior half. The benign lesions like osteoblastoma, osteoidostoma, or osteochondroma, aneurysmal bone cyst. So this osteoidostoma, this can be one of the reason for pain, unless you elicit a good history. If you just take X-ray, you might easily and you may go for further advanced imaging like MRI, and it might not be picking up. So these are all things which you must, a careful history and an examination will tell you what is the problem. So these are benign lesions are common in posterior elements, and anterior body, the malignant lesions are common. So this is an example. So a swelling in the posterior aspect. So CT scan revealed an osteochondroma of the spinous process, which was enucleated, which was excised. Then, having said about the different tumors happening at different age group and different regions, now let us concentrate more about the tumor itself. So first you find out whether the borders. So if it is sharp and sclerotic, it means the bone has had enough time to respond to the pathology. So it is a benign lesion. So it is sharp, sclerotic, so that tells the activity of the tumor. If it is sharp and lytic, still it can be benign, but the bone is not responding, but it is very sharp. If it is ill-defined, then it means that it is malignant. First is the border, then this is very, very important. Everyone must know the zone of transition. So this tells whether it is benign or malignant. A small zone of transition, the tumor you are able to clearly demarcate normal bone. So that is a benign tumor. If there is a broad zone of transition, it tells that it is a very aggressive growth. So if you can see, this is a narrow zone. So it is osteolytic. There is no sclerotic border, but still the borders are very, very well defined. So there is a wide zone. There's an osteosarcoma, you can say, where the lysis ends, where the osteoblastic activity, where the normal bone is found. So you're not able to find out. So this is a wide zone of transition. So that tells that it is a malignant. Then about pattern of bone destruction. So how this tumor is destroying the bone. So it can be directly because of the tumor or by the increased osteoclastic activity. So this cortical bone is less destroyed compared to the cancellous bone. It can be easily destroyed, but it can be easily visible, the cortical bone destruction. Cancellous bone, till 70% of the bone is lost. You will not be able to see it very clearly in the X-ray. So the bone destruction, you can divide it into whether it is geographic, a very clear pattern, a moth-eaten appearance, or a permeative. Permeative is the worst, very rapidly growing tumors. So you can see whether it is a geographic border or a moth-eaten, so like a moth which is just nibbling off the leaves. So it has an appearance like that, or a permeation, where you do not know whether this is a normal bone or is it a continuation of the lytic. So for a long distance, it will not be, you cannot differentiate. So that is a permeative bone type of destruction. So these are all the words you must say. A geographic type of destruction is there, a moth-eaten type or permeative type. Then regarding the periosteal reaction, even some benign tumors, there can be a periosteal reaction. Doesn't mean that the periosteal reaction, Codman's triangle, it is only osteosarcoma. Periosteal reaction, lamellated appearance, Ewing's tumor. So there can be other, because whenever the periosteum is lifted off the bone, cortex, then the body has a tendency to lay new bone. That's it. So an expanding bone, if the tumor has come out and if it is lifting the periosteum, so in a chronic osteomyelitis, it can be there. So many other conditions, the periosteal elevation be there. So these are all benign. So it can be a solid buttress. So tumor is there, it buttresses, there is no interruption, it is a solid periosteal elevation. And this is the tumor. A solid longitudinal or solid undulated. So no interruption, so just an elevation. So here you see a malignant. So a perpendicular, this is because of the blood vessel, the bone is laid down on the blood vessel, so it is perpendicular as the blood vessel it's entering. It can be velvet type, which is just a brush-like border. A lamellated, so there are various layers of bone which are slide. It is not solid. So that tells that it is malignant. And a Codman's triangle. So how to differentiate between this and this? So there can be some fibers like which is coming out. It can be interrupted. So this serrated margin of the periosteal elevation tells that it is not a benign periosteal elevation. So this type of periosteal elevation reaction you must understand. And the matrix, whether it is a chondroid matrix, the chondroblastic or an osteoblastic or a pure lysis, the bone is not reacting. So there are different types of mixed matrices may be there in a single tumor. So it can be long osteolytic as well as osteoblastic. There may be lytic areas with blastic. Commonly in osteosarcoma, you can see. So you can see fluffy cotton wool-like or solid sclerotic mass may be there in osteosarcoma, which is very, very classical. The chondroid matrix, it can be stippled. This is very, very classical. So you can see like popcorn or stippling of the calcification. What you are seeing? This is typical of a chondroid tumor. So an enchondroma, a chondrosarcoma. So these are all the characteristics which can tell you that it has a chondroid matrix. The stippling of so it is not a uniform wisp of cotton like. So you can see that the stippling calcification which you can see. So this is very, very, so it can be a stippled, flocculent or rings and knots so these are all characteristics of a chondroid matrix. Then one more, some dilemmas can come. Rarely, this can be in the radiology session as well as a tumor can be there. And if you take an X-ray, there can be a soft tissue tumor which can go inside and cause some destruction and produce a lytic area. Or it can be a soft tissue tumor which can grow out of the bone. So how to find out? So the cortex is beveled towards the bone. So the beveling, if you see, the cortex is beveled towards the bone. The epicenter is outside. The periosteal reaction is absent because it is destroying and moving. So you don't see a periosteal reaction. And large mass with a small lesion. So if it is a primary bone tumor which goes outside, so it is within the tumor, the epicenter. And the beveling, if you see, it is the cortex is beveled outside towards the soft tissue. And the periosteal reaction will be present. And it can be based on the malignancy or benign. So it can be, and there will be a significant bone restriction when compared to the soft tissue component of the tumor. So to say that it is a benign lesion or a malignant lesion, to put it in a nutshell, it has a well-defined sclerotic border or a sharp, narrow zone of transition, a lack of soft tissue mass, or if it is there, a solid periosteal reaction will be there, nothing interrupted, and a geographic bone destruction. Whereas in a malignant lesion, a periosteal reaction, if it is there, it is interrupted, and a moth-eaten or a permeative type of bone destruction, and a wide zone of transition. So you do not know where the normal bone is there and where the lesion starts. So commonly a giant cell tumor, when it comes, or when the X-ray is put, can it be a giant cell tumor? There are some variants. So if it is giant cell tumor, this tabular column, I think you'll have to, I need not read the entire thing. So giant cell tumor is 20 to 40 simple bone cyst or an aneurysmal bone cyst or a fibrous dysplasia. So the differentiating features you may have to know when you are, when a case like that, a case like this, if you say aneurysmal bone cyst, I mean giant cell tumor, what are the giant cell variants? So these 8 names you must be knowing. It can be an aneurysmal bone cyst because these are all the tumors where giant cells can be formed, and it can clinically present as a giant cell tumor with minimal changes. So it can be an aneurysmal bone cyst, it can be an osteoclastoma, it can be the giant cell tumor, the chondroblastoma, unicameral bone cyst, chondromyxoid fibroma, non-osteophyine fibroma, fibrous dysplasia, and the brown tumor of the hyperparathyroids. Right. Now we'll go to the polling question. I've got only one question for the students who are attending this. This was a patient presented to me around, say around 1 year ago. So this is a patient, 51 years, curettage and cementing was done 10 years ago, that is around 41. So this is the lesion, you all could see, and the histopathological examination at that time was giant cell tumor, because I was the first surgeon also. So I know that patient very well. So the patient searched and he came to me. So 41 was a little late for giant cell tumor. And for 10 years, the recurrence of giant cell tumor, we all know that it happens 80% of the recurrence within 2 years. So, but it doesn't mean that it cannot recur at any point of time. It can recur. So the histopathological examination was giant cell tumor. Now the patient was coming and presenting with pain and swelling in the same region, distal thigh, for 3 months. So this was the X-ray when I took it. So there are some lesions which are here and which are here. So the advantage of putting in a bone cement is that if there is a lesion, usually you can find out. The osteolysis destruction can be very easily made out. So it is again in the epiphyseal region. So this is the tumor for you to see it a little more clearly. So some destruction happening here, only in this region and in this region. So just distal and posterior. So took an MRI. So the MRI was also showing that some destruction and some tumor which is also lying outside. So these are all the sections which are very significant. So there is a tumor, there is a bone cement, and there is a tumor which has come out on the posterior aspect of the distal femur, exactly in the midline and little on the lateral side. So how to proceed? So this is my polling question. I hope that every one of you please answer, because your identity is not going to be known, and I just want the numbers, what you want to do. A is remove the cement, curate it, and then re-cement it. Second is, B is remove the cement, curate, do a bone grafting, because I am doing it. The autograft or allograft, just put fibular strut, you need not fill the cavity, or if you are favorite, then you can also get, because getting cancellous chips, it is not an issue. And you can also add, because denosumab and zoledronic acid, I think that is a game changer for giant cell tumor. It gives, almost we can say, but it is too early, but very good chance of a cure and prevents the recurrence. So you want to do that. Or already once done, and why you take a chance, resect. I am a tumor, arthroplasty surgeon, I want to do a custom megaprosthesis. Straight away make the patient walk the next day. Or still you want to do a biopsy and wait for histopathological examination and then again go in and do anything. Have they started answering? So if you want, I can give you. We can give 30 seconds.
Yes, sir.
Yeah, so that reasonable numbers, if they have responded.
The polling box is online. So attendees, please type in your option, your answers.
So A, B, C, or D. What is your option? I think if there are enough number of already polled, you can just put the result.
Yes, can we have the poll results? 57% have answered it as D.
47 as D.
57%, sir. 57%.
57 as biopsy.
D.
Biopsy, wait for HPE.
Yes, sir.
Is it biopsy and HP? I am not able to. I'm not sure. B or D?
D.
Yes, Delhi.
Delhi. Biopsy and wait for
Delhi.
histopathological examination.
That is 57. Okay.
And 29% have answered it as option B, cement removal,
Okay.
curettage and bone grafting with adjuvants.
Okay. 27.
Only 17%.
So the rest are in between.
Yes, sir.
17 for?
Resection and CMP.
Oh, okay. So recementation is only rest around 10. Okay. 10 or 6. So because as I was stressing, and I'm very, very happy to note that at this end, people are already sensitized that you have to do a biopsy and histopathological examination before you go ahead and do anything. So the result came as osteosarcoma. So never assume anything. So if it is a malignant lesion, whatever be, it is not for medical legal or anything. Don't think about medical legal aspect, and then you have to, because this world people just like that go for anything, but for your own conscience, I would say. So this is such a radical treatment which is going to be, and it is going to make a change whether this patient is going to survive or not. You have already gone in and you have already done something. You have done something which is inadequate. You have done something which is without searching for anything else, and you are doing, then that is absolutely wrong for the patient. So the 57, I really appreciate them that they wanted to do a biopsy and histopathological examination. So it was an osteosarcoma. It was totally everything, all the workup was done, and the surgical oncologist wanted an amputation. He doesn't want anything else. So ultimately the patient went in for amputation, but the patient did not survive for long. So before I conclude, few points I would like to say. First, decide whether it is benign or malignant before you say anything. Never. So I'm very happy that 57 and the rest of the 43, I think those who have listened definitely will not go ahead without doing a histopathological examination. So never proceed without doing a histopathological examination, however confident you are, unless it is an osteochondroma. So don't say that, sir, you have told me, so I'm just doing a biopsy of osteochondroma and then I'm going again. So don't do that. So those cases which you know it is benign based on all the other criteria, then you can go ahead and do it. So not for anything borderline or aggressive. Never do it without a histopathological examination. And your treatment priority, you always remember, first is giving an adequate tumor clearance, whether it involves radical surgery or whether it is going to be limb sacrificing. Anything, first priority is for the survivorship of the patient. So tumor clearance, then the survival of your procedure. I see this, I wanted to tell you because there are so many people are there. I just, this moment I am telling you, for a lot of giant cell tumor, straightforward giant cell tumor, lot of places, lot of young orthopedic surgeons, they straight away go in for custom mega prosthesis. I really want to tell them they are all highly constrained implants, a custom mega prosthesis. So with such an amount of constraint, with such a big bone which has been replaced, and with such a small stem which is going to be there in the medullary canal, it will loosen. Even if you put the top most priority, technically good process, imported designed prosthesis, their survival is not that much. So this is after all a locally recurring tumor, aggressive tumor. So first chance you have to give the patient's own joint. There are so many methods which have come, I think you have to see. Otherwise, if it is not possible, there is no bone, try to do something. Don't try to preserve the joint function, try to fuse the joint. The patient's life will be the same. If you do a custom prosthesis, very well done, patient is walking the next day, 10 years later, if comes with loosen the implant, the patient is around 35, he comes after 45. You have done the best. 45, what is the option you have got? So never take custom prosthesis lightly. If the survival is not there for the patient, then probably just to give a quality of life you can do, but not for a tumor which is locally aggressive, a custom prosthesis. So never do that. So always have other priorities, other options rather than doing a resection and custom prosthesis. Finally, the function comes. So in a tumor surgery, the priority you must have it very, very clearly. So with that, I wish to conclude this. I again thank IORS team for having given me this opportunity. Thank you once again.
Thank you very much, sir. That was a very wonderful and excellent lecture for every postgraduate, and it's always important for every practicing orthopedic surgeon as well. And it was a wonderful lecture with lots of basic clinical examination points, wonderful differential diagnostic points. They should take care of every aspect of the tumor, the radiological findings. It was really full of information, loaded with information, sir. Now we'll take on some questions from the attendees, sir. I'll ask them.
Sure. Yeah.
The first question, sir. What is a satellite lesion? Satellite lesion. He wants to know about a satellite lesion.
Yeah, a lesion which is away from the original tumor. You have to take the entire imaging, and if it is there, probably anything else I don't know, because I'm not a tumor man. If there is anything, any other thing, you may have to say that. Please pitch in and say.
Okay, sir. Thank you, sir. And there was one more question regarding transition zone, but I think you have explained it clearly in your talk, sir.
Yeah,
it is very clear. The other one is how to proceed with benign osteolytic metaphyseal lesion with pathological fracture extending to proximal tibia or distal femur.
Benign osteolytic lesion extending to the a metaphyseal lesion. So what is the tumor, like aneurysmal bone cyst or something they are expecting?
Yes, sir. Yes, sir.
Yeah. So once they have made the diagnosis and it is a benign lesion, so they have to adequately image and find out where it is, and then they have to support the bone, whether by curettage, or they have to see the column, which columns are all involved. So they have to always biomechanically think, as an orthopedic surgeon, always feel that that is not there. The stability of the bone, how the patient is going to bear weight in that bone. So what is the support the patient is going to need? So you have to adequately curate and remove the lesion. Intralesionally, you have to go and you have to curate it. And if necessary, some sclerosing agent, you can do it. And then once it is done, the tumor clearance is obtained. Our second, being a benign lesion, which he has mentioned, he has to give an adequate support for the bone biologically. So it should be biologically supportive. So if it is a small lesion, cancellous bone, and it is going to incorporate, you can do it. If you are putting a cancellous bone, you can you have to wait. You have to protect adequately. Already a pathological fracture, or a cortical strut you want to put, you have to put a cortical strut so that incorporates very fast. 6 to 12 weeks is the time what it takes for the cortical strut to incorporate. Then they can ask the patient to bear weight.
Okay, sir. Okay. Points well taken, sir.
Yeah.
One more question, sir. Is there any need to send a sample to more than one histopathologist?
That is one thing which you must never do. You never encourage that. So always give the entire. You are working in a government hospital. A lot of times it happens. You don't trust your pathologist. So that is when, because if you are an outsider, you know which pathologist you trust and you will be sending it directly. So always give the entire specimen. Let them do it. Let them process and let them give the entire sample which they have not done, which they have done, along with the slides. You request, everyone will give. We want to have a second opinion. You can just ask them, and if you are not satisfied with that, and if they are not very clear, you can go to a senior pathologist and get that. But never split and give, because the lesion may be in one place, and you have given the split where the lesion is not there. Unnecessarily, you will be accusing. So that is unfair, I would say, to the pathologist.
Yes, sir. You made it clear, sir.
Yeah.
I think question-wise.
Yeah.
One more thing is there's an information that the GCTs can very rarely metastasize to the lung as well.
Yeah.
So it is not just a locally aggressive tumor. Is it so?
That is true. Yeah, that is true. But very few percentage. I have not seen one, because I am interested in GCT and I have been doing. And for all cases, I do CT chest. Yet to see one. So probably senior tumor hospitals who are doing, they may be seeing that. So just because it very rarely it spreads, you cannot say that it always spreads, so you have to treat it as malignancy. So it is still only a locally aggressive tumor and you have to treat it only like that.
Fine, sir. I think
That's all, I think.
that's all, sir. We don't have any more questions, sir.
Thank you so much, sir. It was indeed a very, very crystal clear lecture, what actually is required for postgraduate teaching. It was fantastic, sir. Thank you so much for your time and sharing your knowledge with us, sir. Thank you so much.
Thank you,
Thank you.
Singaravadivelu.
Sir, thank you so much, sir.
Thank you very much
Thank you, sir.
for having
Thank you, sir.
participated. It was
Great
really
time, sir.
wonderful. And I also sort of, brushed up my knowledge as well. Anyway, what all you said,
Yes,
you
thank you.
always ask the exam. So that's
Yes,
quite, you made every point so crystal clear for the boys. I'm sure all of them enjoyed your lecture. I will be disturbing again and again, we hope.
Sir, anytime, sir. So when you say, definitely. The most respected teacher, sir. Yes, sir.
Right.
Thank you, sir.
Thank
Thank
you.
you so much, sir.
Thank you, sir.
very much,
Thank you,
sir.
Jaykumar. Thanks,
Thank you.
everyone. Thank you, Deepak. Thank you.
And we come to the end of that wonderful session. And about the next seminar or the webinar is by Dr. K. Venkatadas. It's about pediatric orthopedics. Topics are Perthes disease and slipped capital femoral epiphysis. It will be a wonderful, informative lecture, a very useful lecture for all the postgraduates. It will be on 6th of July at 8 p.m. And do come and gain the knowledge from the expert in pediatric orthopedics. I welcome you all on 6th of July. Thank you very much for attending.
Thank you. Good night.
Thank you. Good night.
Good night.